Dr. Kibble.
Well, thank you for the invitation. It's great to be in Athens. I've never been here before, and I'm thoroughly enjoying it so far, so thank you for the invite. My conflicts of interest. So I'm going to talk about how we can characterize coronary plaques, and I'm going to focus on the invasive assessment of coronary plaques. I'm going to talk about NIRS-IVUS. What does it tell us, and can it improve our cardiovascular outcomes for our patients? We've seen, I'm not going to dwell on this, IVUS improves outcomes of PCI, there's no doubt about it, and as Nilesh beautifully articulated, the guidelines are likely to change on the basis of that. But not only is it as a short-term benefit, there's a durable benefit out to 5 years. So how can we invasively characterize plaques? Well, many of you will have used virtual histology from the Volcano system. I think it's fair to say it's something that hasn't really taken off in day-to-day clinical practice, and I think there's a combination of reasons. Number one, I don't know that many people believe it necessarily, what it's telling you. And number two, I think you've got to go through slices to determine what components of the plaque are, and that's not helpful. And I guess to be fair, we've just heard as well that OCT is beautiful for understanding the plaque and the cause for a presentation to hospital or symptoms. But at the same time, none of us usually have a core lab type person in their lab who's going to go through measuring the fibrous cap thickness. So I think that both of these technologies, unless you have an extremely skilled physiologist or imager within your cath lab who's doing it all for you, these take time and really are more in the realms of research rather than actually in day-to-day clinical practice. So one option that I think is much more readily available for day-to-day clinical practice is NIRS-IVUS. So it's a very high-quality IVUS, very similar to the Boston HD IVUS, but also has near-infrared spectroscopy as well. So the image quality looks like this on the right, and it's got a bandwidth from 35 to 65, which gives you near and deep field with beautiful images. At the same time as giving you high quality pullback IVUS images, it also gives you a chemogram. So NIRS technology on the pullback pulls back at the same time and co-registers so that throughout that vessel you can see exactly where the highly lipidic plaques are. And again, I'm simple and I want to see simple imagery to help me guide what I want to do and the risk to my patient. And if I see a big splodge of yellow, then I know that there's a large lipid burden. And if I see it as red, then I know that it's probably going to be a normal vessel without large lipid core burden. So this is an example within a STEMI case. Of course, you're going to expect the most amount of lipid ever pretty much on a STEMI plaque that's just become thrombotic. And you can see that once you open up the vessel and do your IVUS pullback to size whatever intervention you're going to do, you can see there's a huge amount of lipid core in that culprit area. And this is one of the first studies in 2016 which showed that, of course, in culprits, there's a very significantly higher LCBI compared to those in non-culprits. So that's pretty straightforward in where it's obvious what the culprit is, but I guess what we want to know more is what about stenoses that are not necessarily flow limiting. So like this one here in a proximal right coronary artery, FFR negative, patient is treated medically, but they do a NIRS-IVUS and it has a high LCBI4, and that's at 525, which is a very high reading. And then the patient represents 8 months later with an ACS, and again, this was predictable from that NIRS-IVUS performed 8 months previously. So what does LCBI tell us? Well, the higher the number, the worse the outcome, the more MACE events, and you can see it's relatively exponential once you get above 300. Not only that, but in patients where it's less than 400, they have a threefold less MACE event rates out to 4 years. So I think you can see fairly reliably in this predominantly observational data that high LCBI is bad, and cutoffs of 325, 400 are where you would want to be below. Let me give a case presentation. So a pretty standard case, a 76-year-old male, diabetic hypertensive with poor LV, and he was actually part of the CHIP-BSIS 3 study, which is looking at impeller versus no impeller unloading, and he was randomized to no impeller. You can see he's got a pretty horrible looking LAD as well as a circumflex, which you'll see in a moment, and the diagonal is relatively unpleasant with some calcium opposite the diagonal. And there's the circumflex. So we do a lot of physiology in our centre, and we're putting all of these patients into the physiology sub-study of CHIP-BSIS. You can see a profoundly positive RFR, as you would expect, a profoundly positive FFR, and personally, we tend to do IMR CFR with most times that we give adenosine to get the complete picture, although it's not particularly useful in this particular patient. So the NIRS-IVUS, you can see, has a score of 721. So bear in mind, this is a chronic coronary syndrome. This is an angina patient. This is not an ACS patient. But you can see from that, he's got a huge score in and around the most severe part of the narrowing. So we get on balloon, shockwave and stent, and then POT and optimize. We get reasonable physiology, 0.91. We heard all about how the higher the post-PCI physiology, the better the outcome. 0.85, so non-ischemic at the end in the LAD for FFR. But if you look at the NIRS-IVUS and the chemogram, you can see you've still got a residual after stenting of 443. And you can see most of the lipid within the stented segment has either been redistributed, embolized, or behind a stent, but you would see it. But you can see, and I draw your attention to the proximal part of the vessel, which we have not treated, still has a extremely large lipid burden. So the final result we were pretty happy with, but again, if you look in the circumflex after the area that we've stented, there is still some long segment of disease which is not flow limiting. So when we came to IVUS, the circumflexed, you can see that our stent looks good, and there's very little lipid in and around the stent. But if you look distally, there's still a score of 478. So again, there is significant risk and lipid core burden for this patient. So we concluded on the basis of this that physiologically we'd done the best job that we could, but that this patient still remained at a very, very high risk of further MACE events. So how might the NIRS help us? Well, we know that, again, with observational data, that the higher the LCBI within your stented segment at the index, once you put your stent in, then the worse the outcome. And you can see here with a cutoff of 200 within your stented segment acutely, you have a threefold increase in MACE if you have greater than 200 within the stented segment. But what can we do about it? Well, we can do two things, really. We can do systemic things, which are always going to be drugs, whether that's PCSK9s, aggressive statins, control of other risk factors. And of course, we can do local therapies like stenting, like absorb scaffolds, like the drug-coated balloons. This is from the Pac-Man trial. So you can see that with this small number of patients, you can see that the LCBI reduced from 450 down to about 200 in the space of 8 months with PCSK9 inhibitors systemically. And you can see, looking at that chemogram, it's a much happier chemogram. There's much less yellow lipid. And if you look on the right-hand side, the characteristics on OCT have also improved. So what can we do locally? Well, there's 2 ongoing trials to look at what you can do to this component of the vessel that is not flow limiting, but is at high risk of event. The PREVENT trial is looking at exactly this. So FFR negative vessels that have high risk features. And you can see you need to have 2 of those 4 high risk features. And a large number of patients, 1,600 patients, randomized to either medical therapy, good medical therapy for that lesion, or PCI, if you like, almost in a prophylactic way with good medical therapy, and looking at the endpoints of target vessel failure at 2 years. This will be reported imminently. I don't know which meeting it's going to be, but I would imagine it may well be the ACC coming up imminently. And the final thing, which I think is of real interest, I don't know what it's like in Greece at the moment, but in the UK there is a huge sort of resurgence, I would say, of balloon angioplasty with DCB to prevent restenosis. And I don't know whether it's a fad. I think the SOLUTION trial, which is a trial looking at de novo DCB, will help us. But let's imagine that we could have pacified that proximal segment just before the stented segment with a drug-coated balloon, and that could improve and pacify that plaque locally as well as using powerful systemic agents. The answer is we don't know, and this is a trial that's coming up called the DEBUT LRP study that's going to start a pivotal trial imminently. So in conclusion, Near's may be in the future. It does provide fantastically high quality IVUS imaging, which we know is good for our patients and good for our PCI results. Looking at, we talked about culprits with OCT. I think this can help. If you find areas that do have an extremely high burden, then they may well suggest that that's the culprit lesion. This can be particularly useful if you've got a circumflex and a right and you really can't tell which lesion is the culprit, although you may choose to use OCT with the better quality imaging. We found that we are extending our stent length slightly. So if you see a big lump of lipid outside by 5 millimeters, the bit that you're planning to stent, you will probably cover it, knowing the data that I now know. It will certainly help me understand the lesion and sort of predict CV outcomes in a more personalized way. It may well personalise pharmacology for these patients better too. At the moment, we go for a one-size-fits-all. You just wonder if we know that patients are really, really uber high risk because of these characteristics, that we may individualise things further. I think future pharma trials may well focus on this, so what particular drugs in an enriched population can improve this as a surrogate marker of MACE and risk. And I do think it's likely that CT coronary angiograms are likely to be able to give us this type of plaque morphology in time. And there's a number of players out there. There's one in Oxford and one in Cambridge in the UK who are producing algorithms that are going to look at plaque morphology from the CT. Of course, in a chronic coronary syndrome, most of what I've discussed here is more likely to be useful in an acute coronary syndrome. And on that note, I'm going to stop. Thank you.
Thank you very much, Dr. Kibble, for your talk. We'll discuss at the end. But just a brief question. Do you believe a high lipid value identified by Near's IVUS is predictive of a no reflow phenomenon?
There is some data to support that, so yes. There's some data.
What can we do for this?
Well, so there's a study that shows that in STEMI, the higher the LCBI, the higher the IMR, and therefore the higher the MVO. My practice, whether this, I don't know if this is just a personal thing, but I size my stent in STEMI and sorry. No, I just go the right size first time, and I try and avoid post-dilatation. So, and then I wouldn't necessarily chase post-dilatation if I think I've got a good IVUS run after it. So rather than chasing IVUS perfection of my stent, I would settle that it's not maybe quite as big as it could be. And actually, it was Grigoris's thesis was looking at how IMR changes with post-dilatation. So yeah, I would go for a decent-sized stent and not post-dilate.
Okay, thank you. Okay, we'll go on. Our last speaker is